now and talk about platelets. So platelets are actually not full cells, but fragments of these cells called megakaryocytes. And so they get made or regulated by thrombopoietin, right? So if you notice when we're talking about these different molecules and hormones that are being made, that the beginning of it always kind of correlates to what we're making. And so platelets are also known as what's known as thrombocytes. So that's where this comes from. And so these small fragments of cells contain several chemicals involved in blood clotting. And so there's normally about 150 to 400,000 platelets per mil of blood, and they age quickly and degenerate or fall apart in about 10 days, right? So let's look at thrombocytes and how they're made. And so again, we start with the hemocytoblast. That's the stem cell for all of the different elements that we've talked about today. And then once we get past this, it becomes or develops into a megakaryoblast, right? And this is stage 1. And from here, it's going to grow get bigger, and start getting these vesicles that contain all of these different, basically, chemicals that we need for blood clotting. So you're going to start seeing in here, you see, they're going to start having things like serotonin or calcium, enzymes that are important, ADP, and platelet-derived growth factor is all going to be within here. And these are all the different types of chemicals that are involved in clotting. And so what you'll see here is that over time, they're going to come out and kind of pinch off and make these small kind of fragments of the cell. And so the getting bigger and growing here in stage 2 and 3 are starting to make those basically vesicles that have all these different clotting factors in there. And then stage 4, you're going to see them start clumping off here, and then they derive into thromboplasts, or otherwise known as platelets. And so they function basically to form a temporary platelet plug. That helps to seal breaks in blood vessels. And so as they circulate around, these guys are kept inactive. They're not working. There's no sense in starting to activate clotting if there's nothing there. And they keep inactivated and mobile by nitric oxide and prostacyclin. And these are basically released from the epithelial lining within blood vessels. Now let's talk about hemostasis, because hemostasis is the reaction that stops bleeding, and it utilizes platelets in that process. So it requires clotting factors and substances released by platelets in injured tissues. And so there's 3 steps involved. There's step 1, which is vascular spasm, step 2, which is platelet plug formation, and then the final step, coagulation, which is blood clotting. And so let's go into this hemostasis here and kind of look at what's happening. And then we're going to get into basically coagulation at the end. So the first thing that you see is the vascular spasm that's happening here. And basically you have smooth muscles. So you see here You see here that you have some kind of opening in the blood vessels that you have. And so basically you're going to get a spasm, which is a smooth muscle contracts causing vasoconstriction. So the spasm that you have here essentially is triggered by direct injury of the vascular smooth muscles, from here you're going to have chemical that are released by the endothelial cells and platelets. And you can actually have pain reflexes that activate the spasm. This is most effective basically in smaller blood vessels. And so this vasoconstriction there is going to reduce blood flow because we don't want to bleed out, right? And this chemical, a big part that helps this happen is serotonin. Now, step 2 that you're going to see is that you're going to get a platelet plug formation happen. So what's going to happen is you have that injury that's here, right? And that exposes collagen fibers. So because the collagen fibers are exposed when the vessel is damaged, platelets are going to stick to it. Now, platelets generally don't expose or stick to intact vessels because collagen's not exposed. Also, as I was saying earlier, you had nitric oxide plus prostacyclin that normally gets released by the lining or this endothelial cells. So that generally makes it so that platelets don't stick. Right? But in this case, platelets are going to start grabbing onto those because collagen fibers are now exposed. Now, there is a factor known as von Willebrand factor that helps to stabilize this platelet collagen adhesion. And so if you can see here, you're going to get some platelets sticking on there. And so once they're activated, these platelets start to swell. Okay? And they start releasing chemical messengers. For instance, ADP is going to cause more platelets to stick and to release their contents. You'll also get serotonin and thromboxane A. And this is essentially enhances, like I said earlier, these vascular spasms and platelet aggregation. And platelet aggregation is just platelets sticking to each other. And so this works all by positive feedback. As more platelets stick, they release more chemicals, which causes more platelets to stick, which causes more chemicals to be released, yada, yada, yada. And then the last step is this coagulation, and this is where fibrin forms this mesh and traps red blood cells and platelets, forming this overall clot. So in this sign, you start getting where blood is being transformed from a liquid to jelly-like. And there's a series of clotting factors that are called coagulants that help with this reaction or this clotting mechanism to happen. These are mostly plasma proteins, and they're numbered from 1 to 13 in order of discovery. Vitamin K is important for synthesizing 4 of them, right? And so this guy actually happens in 3 phases, which is what we're going to talk about here right after we get done with this. So just to let you know, this is great for very small vessel tears. But if we need larger vessel tears, we're going to have to do more here. So let's go into coagulation and what's actually happening here. So there's a couple phases. There's phase 1 and phase 2. And so the first phase essentially is composed of 2 pathways. There's both one that's known as an intrinsic pathway, and an extrinsic pathway. So in the intrinsic pathway, we're basically looking at this endothelium vessels rupturing, exposing the underlying tissue like collagen. In the extrinsic pathway, you're getting where it's opening all the way up. And so the tissue cell trauma exposes blood to the outside of the vessel, where this one, it never exposes the blood outside of the vessel, right? And so in the intrinsic pathway, you'll notice that platelets will cling to this collagen and the surface and mobilize factors. And so basically, if you see, you have all these factors in there already. And so this very first one is factor 7, right? Then you see that this is 11 and this is 9. And so they're there, but they're in their inactive state. And so essentially what happens here is that you're going to get, once in this intrinsic pathway, once the surface of that vessel gets slightly ruptured, it's going to change the charge on the surface, and that is going to basically take the inactive state to active. And you can tell they're active because now they have the A next to them. So your 7 is going to be inactive, and then the negatively charged surface that you find on, say, active platelets that are activating or attaching onto the collagen is going to provide the necessary mechanism to change the clotting factor 7 to active clotting factor 7. That is going to be what essentially comes down and activates 11 to be into active 11. And then this, for 9, can come in along with other activated factors to make 9. And then you see as they go through what we're doing to make the fibrin. Now, those are the mechanisms involved in the intrinsic pathway. The extrinsic pathway isn't labeled that because essentially you have blood that releases to the outside. And so The factors that are needed for clotting are located on the outside of the blood, where these are on the inside, where the blood is. And so here you have tissue factor. And so this gets triggered by the exposure of blood to the outside. This is also known as factor 3. Now, if you notice that this can essentially activate, you get this factor 3 that comes in with calcium that will work to essentially go straight down here, right? Into this basically 7 active kind of complex. Or if it's released, you can take 7 and then the activated can go into here to work on the intrinsic. So this guy right here is missing a lot of the steps from the intrinsic. So this pathway over here is faster. And it makes sense that it would be faster because this side is more detrimental. Blood is actually leaving. So at this point, it comes down here to activate 10 into 10 active. Or you have this series that comes over on this other side that's on the intrinsic that is coming down here to perform the same function. So a lot of times, guys, that both of these pathways are working together, right? It's a series of these events that help to activate these procoagulants in this cascade to essentially take factor 5 right here to activate it, right? And so the whole purpose of this is phase 1, right? So that we can basically get this prothrombin activator ready. And so this is going to consist of factors 10 active, 5 active calcium, and phospholipid surface. That's negative because of the platelets. And then basically the reason why we want this is for phase 2 and 3. Phase 2 takes this prothrombin, which is factor 2, and then essentially changes it to active thrombin. And then thrombin is there to take the fibrinogen to activate it into the insoluble polymer fibrin so it can make this cross-linked fibrin mesh. And that again is due from factor 13 that comes in, activates it along with calcium. So this is basically going to be reviewed through by looking at the case study that you're going to be working on. Now, anticoagulants are factors that normally dominate in blood because we don't want our blood to coagulate for no reason, because then it'll get thick and we'll have issues with blood being able to flow through our vessels normally, right? And so we don't want that to happen unless there are problems. So this is what it looks like within a scanning electron microscopy. And basically that fibrin mesh that gets there to kind of stop. And then erythrocytes get caught in it so that they can continue to flow out so that we can minimize basically blood loss. Now, once the clot is stabilized and the damage has been repaired, we need to remove the clot. And so we do that through what's known as clot retraction and fibrinolysis. So fibrinolysis and clot retraction are the two things that essentially we use. Let's see. So with clot retraction, sorry guys. What we basically have is the proteins actin and myosin are in platelets. And so what we do in about 30 to 60 minutes, once the damage is repaired, they essentially contract. So this is in platelets, contract. So this is within 30 to 60 minutes. And so why do they contract? Well, the contraction pulls on the fibrin. And it's going to squeeze out all the serum from the clot. And basically, this serum is plasma minus the clotting protein. And so the big part of this and why it's doing this is going to allow the ruptured blood vessel edges to come together. So the vessel is essentially healing even as clot retraction is occurring, right? And so during this time, we have what's known as platelet-derived growth factors. These are being released by platelets, and this is helping basically to stimulate the division of smooth muscle cells and fibroblasts to rebuild blood vessels. And you're getting VEGF, which is called vascular endothelial growth factor. And these are stimulating endothelial cells to multiply and restore endothelial lining. So clot retraction is basically trying to stabilize and remove damage once it's repaired. And as you're doing this, then you're bringing about the, trying to bring together the blood vessel edges so that we can essentially, at the end, be able to come together and have the sides grow together. So that's clot retraction. Now, fibrinolysis is the process that we want to remove clot. After repair. And so it goes from, it begins within 2 days and it continues until the clot is dissolved. And so basically we have this thing called plasminogen. And so this is trapped in the clot. And basically this guy gets changed or converted to plasmin. And this guy is a fibrin digestive protein. So it's going to break up fibrin once fibrin is done doing its job. And so these are the two processes that are happening as we are actually making our clot. Now, just a reminder, what's helping to heal the clot or heal the vessels is platelet-derived growth factor, which you will see as PDGF, and VEGF, which is vascular endothelial growth factor. So this is what activates smooth muscle and fibroblasts to redo the vessel wall. And this helps endothelial cells repair the endothelial lining inside of the vessel itself. So these are the two guys that are working to fix it while clot retraction is happening. Okay? So there are factors that limit normal clot growth. The two mechanisms that limit the size are the swift removal and dilution of clotting factors that are there as they become going from inactivated state to activated state, and the inhibition of activated clotting factors, right? So those make sure that clot sizes stay to a minimum to where they need to be to stop the clot or stop the opening of the blood vessel, but not to basically make it so blood can't flow through it. There's also a limited amount of thrombin that's there and is restricted to clot by fibrin threads, preventing clots from getting too big or escaping into the bloodstream. Right? Factors preventing undesirable clotting are the factors that prevent plate adhesion, right? And so antithrombin inside the blood basically inactivates any thrombin that's in the blood that doesn't need to be activated or escapes from the clot itself, so that this isn't going to activate and move that clot farther outside of the damage. Now, just to get you, there are certain things that we take, for instance, like heparin, that enhances antithrombin 3. So disorders of hemostasis, there's two major disorders. There's the thromboembolic disorders. These are the disorders that result in undesirable clot formation, and essentially bleeding disorders that lead to abnormalities that prevent normal clot formations. So basically, when we're looking at DICs or disseminating intravascular coagulations, basically it involves both types of disorders coming together. So let's really quick talk about some disorders of hemostasis. So a thrombus is a clot that develops and persists in unbroken blood vessels. I'm putting BV for blood vessels. This may cause blocked circulation and lead to tissue death. An embolus is a thrombus that is freely floating in the bloodstream. An embolism is an embolus that obstructs a vessel. So example of this could be a pulmonary or cerebral emboli, right? And so the risk factors for these can be stuff like atherosclerosis, which is the hardening and the blockage of major arteries, right? Inflammation, slowly flowing blood, or blood stasis from immobility. Now, there are anticoagulant drugs. These are used to prevent undesirable clotting. So aspirin is one. And this is an antiprostaglandin. And basically what it does is it inhibits thromboxane A. Heparin is an anticoagulant that's used clinically before and post-operative for cardiac care. And warfarin, also known as Coumadin, is used by people that are prone to atrial fibrillation, and we're going to talk about that more in the next one. It interferes with the action of vitamin K. Right? So, bleeding disorders, you can have problems when you have impaired liver function. And so with impaired liver function, it makes it so that you have an inability to synthesize the coagulants, or otherwise known as clotting factors. It can also have problems or cause includes vitamin K deficiency, hepatitis, or cirrhosis of the liver. Problem with this, it isn't just included if you have liver disease. It's not just possibly causing some bleeding disorders, but it can prevent liver from producing bile, which is needed to absorb fats and vitamin K. So there's a lot of issues that can happen here. Hemophilia is a genetic disorder. Okay. There's both A and B. A is the most common, with about 77% of all cases being due to hemophilia. And it's basically due to factor VIII, right? Hemophilia B is a factor IX deficiency. Hemophilia C is a factor 11 deficiency. But factor VIII tends to be the most common, right? And basically what this leads to is things like prolonged bleeding, especially in joint cavities. And treatment is injection of genetically engineered factors. And so this has eliminated the need for plasma transfusions and the risk of actually contracting hepatitis or HIV. DIC, or disseminated intravascular coagulation, basically involves both widespread clotting and severe bleeding. Widespread clotting occurs in attacked blood vessels and block blood flow, and that's the problem. And severe bleeding follows because residual blood is unable to clot because clotting factors are being depleted because of these basically activating blood clotting where you don't need it to be. So it can occur in septicemia, incompatible blood transfusions, or complications in pregnancy. So let's talk really quickly about blood transfusions, a little bit about blood typing, and then we're going to be done with this section. So cardiovascular system minimizes the effect of blood loss by reducing the volume of affected blood vessels and stepping up the production of red blood cells. The body can compensate, but only for so much blood loss. Basically, loss of about 15 to 30% can cause pallor and weakness, change of color, right? Loss of more than 30%, though, can result in potentially fatal or severe shock. So with that case, then we're going to do what's known as transfusions. So you have whole blood transfusions, which are only used when blood loss is rapid and substantial. We have infusion of packed red blood cells, or what's known as PRBCs, which have the plasma and the white blood cells removed, are preferable to restore the capability of carrying oxygen, because that's one of the big problems with losing a large amount of blood. Now, the thing is, when you are doing this, you need to make sure that the blood that you're giving the individual is going to be compatible with them, right? Because if you get something known as a transfusion reaction, it can be fatal. So what we do is you have blood banks, and they are basically, you can donate your blood there, and they usually separate donated blood into components. The shelf life of blood is somewhere about 35 days, right? And so when we do this, when you are going to take a transfusion from somebody, you want to make sure that you have the correct blood typing go. So human blood groups, there are at least 30 naturally occurring red blood cell antigens. Presence or absence of each antigen is used to classify blood cells into different groups. And if you remember, the antigen is a particular protein binding site or protein site that's on the outside of red blood cells. So you can have one type of protein that's an A antigen, another type that's a B antigen, and the O means that there are no antigens present. And those are all dictated basically by your genetics from your parents. So if an antigen is foreign to you, basically your body is going to produce an immune response against it. So all of these red blood cell antigens are referred to as what are known as agglutinogens, because they can promote agglutination, which is the response of antibodies attacking that antigen site. And you have the ABO in the RH blood group. RH is a D binding site. They cause the most rigorous transfusion reactions, as in your body attacking the blood if it doesn't recognize it. So they're the major groups that we type. So it's based off of two of these antigen surfaces, A and B on one, and then that's what's known as anti-A or anti-B. Antibodies will be made against the antigens that's respected. Anti-A or anti-B form in the blood at about 2 months of age and reaching adult levels by 8 to 10 years of age, right? And so there are, in the RH group, there are 52 named RH agglutinogens, RH factors. C, D, and E are the most common types, and I talked about D being earlier. And so 85% of Americans are RH positive for having one of these. And so we've talked about this in class already. And so if you have a blood group that's AB, the antigens or the binding sites that you'll have on your blood are A antigens and B antigens. And with that be in mind, that means you will have no antibodies against those because your body recognizes them as being normal. So the blood that you can receive from somebody is blood that's A, B, AB, or O. O means that there's nothing on them. And so this kind of gives you the frequency. And so for an AB blood type, you have about 4% of the Caucasian or white population has this, 4% Black, 7% Asian, 2% Hispanic, and less than 1% Native American. Now, if you have B, then you're going to have the B antigen, and so you're going to make antibodies for A. And so you can, for this one, you can receive blood from B and O. So population here is 11% of the white population has this particular blood group, 19% Black, 25% Asian, 10% Hispanic, and 4% Native American. So you can see this one's a little bit more common than AB. Now, if you look, we have even A here, which you can see is even a little bit more common for all blood types. And so A, you have the A, B, and C antigens. So on here, you have the A antigen, so you are making antibodies for B. And you can see here on this red blood cell what it looks like. So you can receive blood from A and O. 40% of the white population has it, 26% of the Black, 28% of Asian, 31% of Hispanics, and 16% Native American. So as you can see here, the most common blood type group for all is O. O has no antigen at all on it, so it's going to basically have anti-A and anti-B. It's going to make antibodies for A and B. So you can see here, nothing on that red blood cell, so it's going to be looking out for these guys. This is what's called the universal donor, basically because you can donate it to everybody, but you can only receive from O. If you look at AB, it's considered the universal recipient because you can get it from everybody, but you can only donate to AB. So you can see O has the highest percentage with 45% white, 51% Black, 40% Asian, 57% Hispanic, and 79% Native American. Now, you can get what's known as hemolytic disease of newborns, also called erythroblastosis fetalis. Only occurs in Rh negative moms that end up having Rh positive fetuses. So what happens is during your first pregnancy, an Rh negative mom will be exposed to the Rh positive blood of the fetus during the delivery. The first baby will not have no problems with it. The baby will be born healthy. But now the mother, since it's been exposed to something that's foreign, i.e. the Rh factor from the child, they will now start synthesizing anti-Rh antibodies. During the second pregnancy, the mom's anti-Rh antibodies can cross the placenta, and it will actually destroy the red blood cells of any child that they have that is Rh positive, right? Okay, so what will happen is the baby treated with pre-birth transfusions and exchange transfusions after birth so that it can survive. Now they do have this thing that you have this RhoGAM serum that contains anti-RH that can prevent Rh negative mothers from becoming sensitized or creating antibodies against Rh positive fetal blood. So just to let you know, 85% of Americans are Rh positive. So Rh negative is very uncommon. So transfusion reactions is what happens if you get mismatched blood, that it's actually infused. The donor cells are attacked by the recipient's plasma agglutinins, right? And so it'll agglutinate and clog small vessels, rupture and release hemoglobin into the bloodstream, and this can result in diminished oxygen carrying capacity, decreased blood flow beyond blocked vessels, and hemoglobin and kidney tubules can lead to actual renal failure. So it can be overwhelmingly bad for your body. And so death from shock may result from low blood volume after this happens. Or if you lose a lot of blood, right? Volume must be replaced immediately. And so it's normal saline or multiple electrolyte solution, which is known as Ringer's solution, that mimics plasma electrolyte composition will be added if you have low blood volume, and it can help with replacement of volume, restores adequate circulation. But the problem is it does not replace oxygen carrying capacity of blood. So this is one way that you can restore the amount of blood volume, but you're also going to have to allow some kind of red blood cells to come back. And you can do this with blood transfusions that are high, or just using erythrocytes. Now the cool thing is here, you can use diagnostic blood tests to examine a person's health, right? And so you can look at blood tests, and for instance, if you have, sorry guys, if you have low hematocrit, you can basically say, I think someone has anemia, right? You can look at high blood glucose, and you can say, hey, this person might have diabetes. If you have leukocytosis, right, you might tell, and it may signal an infection. And you can actually look at the microscopic examination of blood, and it can talk about, do you have abnormal size, shape, or color of your red blood cells, right? And this could even indicate anemia. So blood tests can be very, very helpful for clinicians to determine if there's something wrong with their patient. You can also do what's known as a differential white blood cell count, and this looks at the relative proportion of each white blood cell. And so increases in specific white blood cells can help with diagnosis, right? And so you can get what are called CMPs, which are comprehensive medical panels, that can look overall at blood chemistry profiles and can check various blood chemical levels in there to see if things are right. When you're looking at blood tests, you can look at prothrombin time and platelet counts to assess, blood clotting. You can look at the complete blood count, or CBCs, to check formed elements, the hematocrit, the hemoglobin, all of these. And basically, for instance, if you're looking at the Comprehensive Medical Panel, the CMP, it can help you determine maybe if you have a liver or a kidney disorder. So blood tests can tell you overall health easily. And so, with that being said, we are done talking about blood. And the next one is going to be really exciting because we will be going into and talking about heart. See you soon.